Let's look at the ventricular volumes here. So these are going to be really important when we talk about measuring how much blood is actually moving through the heart. So the first volume is called the end diastolic volume. This is the amount of blood that is in the ventricle at the end of diastole. So diastole is that filling phase. It is the phase to which we have blood filling into the ventricle. At the end of the filling phase, when we measure how much blood is in that ventricle, this is called the end diastolic volume. It's the total amount of blood that has filled into the ventricle. Then we have the end systolic volume. This is the amount of blood that's left in the ventricle after systole. So after we had ventricular ejection, when most of that blood has left the ventricle, there is still some blood that is sitting in the ventricle at the end of systole. In other words, the ventricle is never fully empty. And so the volume that's left back after ejection is going to be considered our end systolic volume. The stroke volume is going to be the difference in those two volumes. The stroke volume is the amount of blood that has been ejected from the ventricle. So in order for us to calculate our stroke volume, we take our end diastolic volume, the total amount that was filled. We subtract our end systolic volume, the total amount that is left after ejection, and that will tell us exactly how much blood has actually left the chamber, which is going to be our stroke volume. Okay, so I've got a prompt question here on the slide based upon the events of the cardiac cycle. When do you think would be the best time for us to measure the end diastolic volume or to measure the end systolic volume? Tell me in the chat, which of our four phases do you think would be the best point to measure the end diastolic volume or to measure the end systolic volume? Okay, not seeing any responses. I guess that means we're not too sure. Let's go back and look at the cardiac cycle again. Let's go back to one of these images and talk about these phases here. So if we're trying to measure the maximum amount of blood that has filled in the chamber, we would want to do that at the very end of diastole. Excellent. So someone is saying end diastolic volume when the aortic valves are closed. So that is absolutely correct. So the end diastolic volume is how much has filled into the chamber. And so the best time to measure that would be at the end of the ventricular filling phase, right before the semilunar valves open up. So it would be at the end of phase 2, okay? Or even at the end of phase 1, because we know that the volume doesn't change in phase 2. So at the end of phase 1 would be the same volume, and that would be when the ventricle has completely completed filling, which is the end of diastole. Remember, diastole is phase 4 to phase 1, right? Phase 4 to phase 1. So at the end of phase 1, which is here or also here, that would be the best time to measure the end diastolic volume. The end systolic volume, on the other hand, would be the amount of blood left behind after the ventricle has completely ejected. So the best point to measure end systolic would be at the end of systole. And we know that phase 2 and phase 3 correspond to systole. So that would be at the end of phase 3, which is right after that aortic or pulmonary valve has closed, which means that no more blood is leaving that ventricle. That would be the best time to measure the end systolic volume. So at the end of phase 1 for diastole and at the end of phase 3 for systole. Okay. All right. And so if you look at the numerical values for these volumes, for Stroke volume, it's about 130 milliliters minus 60 milliliters, and that will give us 70 milliliters for our stroke volume. The 130 milliliters is our end diastolic volume. The 60 milliliters is our end systolic volume. And so our stroke volume, which is the amount that has been ejected, will be 70 milliliters. On that basis, we can then begin to talk about the ejection fraction. So the ejection fraction is the amount of end diastolic volume that was ejected. So what proportion of the end diastolic volume was ejected? And in order to do this, we would simply do the stroke volume divided by the end diastolic volume, which is 70 divided by 130, and that would be 0.54 or 54%, and that's at rest. So the ejection fraction is the proportion of the end diastolic volume that has actually been ejected from the heart. So that would be about 54%. So in other words, 54% of our blood is ejected and the rest of that is remaining in that chamber. So 54% is our ejection fraction. All right. And so just to look at what that means here, adding our volumes to these pressure or to these cardiac cycle changes. So here's the start of atrial contraction. Here is where we have that last contraction. So this is going to be phase 1 and then phase 2. And then we have ventricular ejection, which is where the volume drops off. So at the end of phase 1 is where we have our end diastolic volume. So this is going to be 130 milliliters. After we have ejection, we're going to have it remaining 60 milliliters in that chamber, which tells us that a 70 milliliters has been ejected from the chamber. Okay, so 70 milliliters is our stroke volume, which is the difference between 130 and what is left behind, which is 60. All right. Let's talk about the pressure volume curves here. This is how the pressure and volume are changing together throughout each of these phases. So this is just another perspective to look at the cardiac cycle from. And on that basis, we can compare these two volumes on this graph here, and that gives us what's called a pressure volume loop. Because this is a cyclical set of events, this creates a cycle, which is called the pressure volume loop. So in phase 1, the ventricular volume increases from 60 to 130. So notice we start at 60 here. Also notice that the volume never dips below 60 because the heart always has, the ventricles that is, always have some blood in them. And so it's going to start with a volume of 60 milliliters and then rise steeply to 130 milliliters during that ventricular filling phase 1. In phase 2, the volume remains the same. Remember, this is the isovolumetric ventricular contraction. So the volume doesn't change, but the pressure rises. The pressure rises steeply, which gives us this upward stroke in the ventricular pressure loop. So in phase 2, volume is staying at 130 milliliters. Pressure is steeply rising. And then at the end of phase 2 and the beginning of phase 3, we've got the volume dropping. So the curve is going to shift in the opposite direction because when the semilunar valves open, the ventricles can eject blood and the volume will rise. Notice that the pressure is going to rise slightly and then drop off towards the end of that phase 3, the end of ventricular ejection. At the beginning of phase 4, which is where we have the isovolumetric ventricular relaxation, again, the volume here doesn't change. Once we eject 70 milliliters of blood in phase 3, it's going to stay at 60. The pressure will drop off, which is what's happening for the downstroke of the loop here. And that is where the ventricle is relaxing, and we're going to come all the way back down to phase 1, which is our ventricular filling phase once again, where the AV valves would open at this point. So if we compare how the volume and pressure are changing in all 4 of our phases, we create this volume pressure loop, which can tell us a lot about the health of the valves, the health of the ventricles, the health of our systemic vasculature. If we have something, for example, like if we have a leaky valve, let's say we had a leaky valve, we have an insufficiency of the one of our AV valves, the mitral valve, for example, which can happen after things like rheumatic fever, which is an infection that can lead to leaky valves. What we will see is that the volumes will be slightly increased. The volumes will be increased, and so that is going to shift our loop to the right. That's because even during isovolumetric phases, that leaky valve will allow blood to continually spill down into the ventricles. And so that will shift our pressure volume loop to the right. So there are a lot of different clinical scenarios, such as hypertension, left ventricular failure, right ventricular failure, that will cause a shift in the way that this curve looks. We can have a bigger curve, we can have a shorter curve, we can have a curve that's shifted to the right or even shifted to the left. All right, so there's a lot that we can learn from the ventricular pressure loop or curve. Someone is asking, does that decrease the ventricular volume? It doesn't decrease the ventricular volume. It would actually increase the ventricular volume. Imagine if you had an AV valve that was not able to secure shut. It would not allow the ventricles to fill and then eject. It will cause a situation where the ventricles will be continually filling because blood will always be trickling or leaking down into the ventricle from the atria. So that will create a situation where our resting ventricular and systolic volume will not be this low. It will not be 60, it will be much higher because blood will be continually leaking down into that ventricle. And so we're going to be starting off this curve on much higher volumes because of that leaky valve. All right, really good question there. Okay. Lastly, let's talk about the heart sounds. So the heart sounds are kind of where we get into the clinical relevance of the heart cycle. And what causes the heart sounds is the turbulence of blood flow when the valve is closing. So one would be tempted to think that the heart sounds are created by the movement of the valves, and that is not true. What creates the heart sounds is the turbulence of blood flow against the back of the closing valve. So it's really the movement of blood, the whooshing of the blood as it moves past that closing valve. The first heart sound is called a soft lub. It's when the AV valves are closing, right? Both the mitral valve on the left and tricuspid valve on the right, they're closing at the same time. And so the pressure that's caused by that backward whoosh of blood leaving the atria, but hitting against the back of the closing AV valves, that is what creates the soft lub, which is the first heart sound. The second heart sound is a louder dup. And so that is caused by the opposite set of valves. That's that last bit of blood shifting against the back of the semilunar valve. So as the semilunar valves are closing, that last bit of turbulence or blood that's moving, which creates that turbulent sound, is what gives us that louder dup. And the reason that it is louder is because we have more resistance in the systemic circulation and in the pulmonary circulation. And so it's a louder whoosh against the back of the semilunar valves than it is against the back of the AV valves. So if we think about the heart sound, it's a lup dup, lup dup, lup dup, so a softer lup and then a louder dup. That dup has just a bit of a lingering, and then we get back into that lup. So lup dup, which is going to create our two heart sounds. Okay, so when you're listening to patients, you're putting your stethoscope against the chest. These are the sounds that you're auscultating for. So you'll auscultate in the aortic area, you'll auscultate in the mitral area, in the tricuspid area, and you're listening for the smooth flow of these sounds. If there's any delay in these sounds, or if there's any difference in the pitch, that will tell you about the health of the valves, whether there's a stenotic valve or a leaky valve or any type of valvular insufficiency happening. that can be picked up by listening to those heart sounds. Okay. Let's look at a few practice questions here. We've got a few minutes left for a few questions. So let me launch a poll, and then we'll see if there are any questions that come up. All right, 5 more seconds. All right. Does the heart spend more time in diastole or systole? So this is diastole. Okay, so this is just straight memorization. I think we mentioned this earlier. The heart spends 2/3 of the time filling. That is so that it can have adequate amount of blood to be forcefully ejected. So if the heart is not filling enough, it cannot have enough volume to eject. So the heart spends more time in diastole. Okay. Someone down here, not someone, excuse me. One of the options here is atria spend more time in systole, ventricles spend more time in diastole. So this is something really important to point out. When we talk about the cardiac cycle events, we're talking about them from the perspective of the ventricles. So when we say things like isovolumetric ventricular contraction, or isovolumetric ventricular relaxation, or ejection, we're really looking at the cycle from the perspective of the ventricles only. We're not necessarily looking at what's happening in the atria. So while we are describing the events of how blood is moving from the atria to the ventricles, when we talk about filling versus ejection, that's always going to be from the perspective of the ventricle. Okay. All right. Let's look at a few more. All right, 10 more seconds. All right. So what is the mean arterial pressure, or the MAP? Looks like most of you went with B. B is average pressure across all arteries during the cardiac cycle. So B is not correct because it's not across all the arteries, right? Some folks did pick A, average aortic pressure during the cardiac cycle. So A is correct. So the mean arterial pressure is specific to the aorta. It tells us information about the rest of the vasculature, but the place that it is measured is in the aorta. So it is specific to the aorta and is across the entire cardiac cycle. So A is correct, right? Obviously C is not correct because it's not in the ventricle, or it's not just during ventricular contractions across the entire cycle. And then also D is not correct because it's just in the aorta. It's not in all the arteries.